Thank you, sir. We now move on to a rapid fire session chaired by Dr. Kumudini Jayasinghe and Professor Namal Vijayasinghe. Please welcome them on stage.
Good morning, all of you. Welcome to the second session of Meet the Expert, rapid fire session, CLOT controversies. On behalf of the Sri Lanka College of Internal Medicine, we have pleasant task of introducing the speaker, Professor Andrew Dunn, Professor of Medicine, Chief, Division of Hospital Medicine, Department of Medicine, Mount Sinai School of Medicine, New York. He's also the ACP ambassador. His primary research area has been in anticoagulation and thrombosis. He's going to unravel CLOT controversies. Over to Professor Dunn.
Great. Well, thank you so much for the invitation. I've had a wonderful time here at your conference and your wonderful country. So I am a hospitalist, and as a hospitalist, CLOTs are important because we're always treating them. Sometimes we're causing them. We're causing bleeding. We're treating bleeding. It comes up all the time. So it's a very important topic for everyone in internal medicine. It's been my area of clinical interest and research interest. I've been on the CHEST guidelines. I run Mount Sinai's anticoagulation committee. So it's a big part of what I do. And today, in a short amount of time, I'm going to run very quickly through 4 important controversies in anticoagulation and CLOT management. Let me start my timer so I know how much time I have. Very good. Okay, first my disclosure is there. So what are our goals for about half an hour? What's the best anticoagulation strategy for our AFib patients on dialysis or with CKD5? Tricky one. How long do you treat someone with a first venous thrombosis unprovoked? When do you thrombolyse submassive PE? And when can I restart anticoagulation, or should I, for someone on anticoagulation who has major bleeding? So let's go. So warfarin, the cows were dying in Wisconsin and the United States, and they did the autopsies. They found a vitamin K antagonist, coumarin, in the bloodstream. The cows were eating spoiled sweet clover. And the Wisconsin Alumni Research Foundation turned that vitamin K antagonist into warfarin, which has been an excellent rat poison ever since. Also a medication, but pretty toxic. So can we do better than warfarin? So first, AFib and end-stage renal disease, very common. You can see that if you're under 60 and you're, AFib is pretty uncommon in the general population. If you're over 80, it goes up to 8%. But if you're on dialysis, you can see the green bars, it's 13 to 27%. Very common in dialysis patients to have AFib. So what's been the standard of care? The standard of care in AFib for patients on dialysis has been warfarin, a vitamin K antagonist, which raises the question, just how good is warfarin in that setting? And the answer is not so great. This is one large systematic analysis of warfarin for AFib in patients on dialysis. This combined 15 observational studies, over 47,000 patients on dialysis with AFib, and they looked at patients on warfarin and patients on a control group. And much to our disappointment, the results you can see, is the pointer working here? Let's see. I'm not sure if this one works or if this one works. Aha, very good. You can see this little diamond here is on the middle line. This is no difference in stroke, no benefit to warfarin in AFib. And the bottom, this diamond here off to the right, worsened intracranial bleeding. So you get harm with no benefit. That's a bit of a scary thought for dialysis patients. And after this analysis came out, KDIGO, one of the world's largest kidney societies, said, until new data becomes available, and in contrast to our prior recommendation, anticoagulation of CKD stage 5 patients with AFib is not indicated. Wow, mic drop moment. We should not be treating them. Now, other studies came out around the same time. Different meta-analyses came out at the same time. We do think there's a benefit for warfarin in AFib patients on dialysis, and that's still been the standard of care. But can we do better? So now the DOACs are out, and in general, the DOACs are more renally excreted than is warfarin. So it might accumulate, and we might be causing massive harm and tremendous bleeding if we're using it in dialysis patients. So what's the data show? So here we have a retrospective study 25,000 Medicare patients on dialysis with AFib. Now, not a randomized study. So 23,000 of them were treated with vitamin K antagonists. 2,000 of them had primary doctors or physicians who were brave enough to treat them with apixaban. And the dose was pretty much divided between the standard apixaban dose and the reduced apixaban dose, and which raises the important question of how these patients do. I'm going to skip over that one. And here you can see the main results from the Scientis study. Off to the left, you can see no difference in stroke or no difference in stroke or TIA, which is disappointing. We like to see a benefit, but most importantly, it did not cause major bleeding. And for me, when I look at the study, that's what I wanted to see. Am I harming my patients by giving dialysis patients apixaban or a DOAC? And the answer was no. In fact, there's a benefit. And there was decreased bleeding here in the apixaban arm. So reassuring results for sure. Now, if you're also like me, you want to know which dose of apixaban you should use, because there's 2 doses available. The standard, this again, not randomized, but the standard dose versus warfarin, there's a small error here. Decreased stroke and death, no change in bleeding. So if you use the regular old dose of apixaban, you decrease stroke and death and no change in bleeding. If you use the lower dose, you get less bleeding, but no change in death or stroke. Unfortunately, statistically, it did not come out that standard dose versus low dose leads to less bleeding with the lower dose. It did not show that, although intuitively you would think that that's what would come from the study. So that observational study supports using DOACs. There's actually a couple of randomized trials. The limitation is that they're unbelievably small. This is a randomized trial. I would love to see a randomized trial here. It's recent, 2022. It's very small. They looked for 760 patients, enrolled about 150 patients, vitamin K antagonist versus apixaban, looking at major or clinically relevant non-major bleeding. They're looking at bleeding. That's what we'd want to see. There was no difference. And again, for me, that's incredibly reassuring, because my main goal here is to make sure that giving them the more convenient medicine is not causing harm. Another randomized trial, 2023, even more relevant. Even smaller, 39 sites, about 100 patients over 5 years. That comes out to 1 patient every 2 years per site, looking at vitamin K antagonist versus apixaban. And if you can see, a little hard, impossible for you guys to see actually, but no difference in the safety outcome of bleeding and no difference in efficacy. So again, you can look at that as disappointing. It wasn't better, but to me, it's more reassuring that it didn't cause harm. So in this first battle, this first controversy, this is King Kong and Godzilla, DOACs can be used in CKD5 and dialysis patients. It remains controversial, but that is my interpretation of the literature. It looks like they're more effective at the regular dose, at least as safe. And then what dose to use, we don't know. We don't know. For now, I would use the package insert, which says use 2 of the 3. 1 is renal, so you already have that one. The other 2 being weight and age. And if you have 2 of those 3, you're going to use the lower dose. Quick look at our time. Very good. All right. Mental break, mental pause, moving on to topic number 2. How long do you treat someone with a first unprovoked VTE? Or should you treat them with lifelong? We love our patients who have bleeding disorders. We don't want to cause one. And when we choose lifelong full dose anticoagulation, we are causing a coagulopathy for our patients with the best of intentions. So let's start with a case. 76-year-old woman, diabetes, heart failure, preserved EF, comes in with acute PE, no RV strain. She gets put on a DOAC like rivaroxaban. She's going to go home. Exam is good. Hemoglobin is fine. Blood tests are fine. But now you have to decide how long you're going to treat this person. If it was a provoked VTE in the setting of fracture, setting of surgery, 3 months is going to be okay. And if it's recurrent VTE or there's active cancer, lifelong. Easier for the doctor, right? Maybe harder for the patient. But what about this person? First unprovoked VTE. There's a lot of options. 3 months, 6 months, 12 months, lifelong, even longer has been studied. There's a lot of options out there. So what do you think about? First, you think of the risk of recurrence. Should I stop? What's the risk of recurrence if I only do 6 months? What's the risk of major bleeding if I don't stop, if I do treat lifelong? What's the risk of waiting for the next recurrence? If you treat somebody for 6 months, then stop, and 3 years later they have a DVT, you can put that person on lifelong anticoagulation then. You didn't lose much. If the next recurrence is fatal, you've lost that calculation completely. What do the guidelines tell me? We'll look at that a little bit. What do you want to do? That's shared decision-making, bringing it right back to our patients and their families. And my favorite, I'm just a hospitalist, go talk to your PCP. But we can do better than that, right? So there's some good data out there. This is one of the first studies, Kira, New England Journal of Medicine. 24 months versus placebo. It was stopped early, and you can see why. The risk of recurrence with indefinite warfarin was reduced to almost zero. 90% effective when you're therapeutic on warfarin. It's not that many medicines that are 90% effective out there. But that raises the question. There was no point in that Kieran study where they were not on anticoagulation. So what if we treated for a year and then checked them out 3 years later? Maybe 1 year is all they need to reduce their risk close to zero. This is the Agnelli trial. And here you can see one group gets 3 months and one group gets a year. And you can see that at the 1 year point, one group, the group assigned to continue therapy, has almost no events. So the group to continue for 1 year is incredibly effective. But what happens at 3 years? So now after 1 year, everyone stops, right? At 1 year, no one's on. At 3 years, they're equal. So giving 1 year and hoping for a prolonged effect doesn't seem to be helpful. If you're going to treat long-term, you're going to treat indefinitely. So what you want to know is the long-term risk of major bleeding during extended oral anticoagulant therapy after a first unprovoked VTE. So this study ended up being quite helpful. This is a meta-analysis looking at exactly that. 27 studies, extended oral anticoagulation after the first 3 months of treatment. It is not a randomized, some of them were randomized. About 10,000 were on vitamin K antagonist, about 7,000 patients were on DOAC. And what you're interested in is, if you treat indefinitely, what's the risk of bleeding and what's the risk of fatal bleeding? And here you can see, this slide has a lot of numbers, letters, rows, columns, a little bit hard to decipher. So let's try to make it a little simpler for us and for me. So you can see major bleeding, should you decide to treat indefinitely, happens about an increased rate of 1 to 2% every year. Okay. Intracranial bleeding, which is dire, happens in 1 out of every 300 patients per year. And a fatal bleed happens 1 out of every 500 patients per year. So for every 500 patients we decide to treat lifelong or indefinitely, 1 will die from the treatment. Okay. Now, what is that balanced against? Oh, and then basically that calculates out to about 1% of patients or after 5 years. So after 5 years experience, 1 death. You balance that with the math of the fatality of a recurrent event. The recurrent event rate is about 5% per year. In general, it ranges wildly per patient. The mortality of a recurrent event is about 4%. If you do the math, the mortality rate after 5 years is also 1%. It's a toss-up, which makes our management decision extremely hard. So is there a way out of this conundrum, this challenging scenario? Maybe there is. This is 2 trials, very similar, so I'll present them both together, looking at a low dose of the DOACs. One trial used apixaban, one trial used rivaroxaban. Low dose may be safer after initial treatment for 6 months. So everybody gets treated, treatment dose 6 months, and then randomized. Low dose of the DOAC indefinitely or placebo. Rivaroxaban did something interesting. They didn't use placebo, they used aspirin, which some internalists will say is as good as nothing, but I won't say that. Aspirin is better than nothing. I think that's on the bottle. Better than nothing. So what do the results show? So in the apixaban study, if you look at the top row here, or the second row, recurrent VTE-related death was 9% in the placebo group, cut down to 2% in the low-dose apixaban group. That's pretty darn good. You cut down to, that's a pretty good, relative risk reduction. Impressive. And if you look at, rivaroxaban, you get a similar pattern with the aspirin group getting 4%, being cut down to 1% with the low-dose rivaroxaban group. Tremendously effective, with no increased risk in these studies of major bleed. Now, one thing you're not supposed to do is compare results across 2 different studies. So let's compare results across 2 different studies for a moment. And if you can see, the event rate was 9% in placebo, was 4% in aspirin. I'm not going to say aspirin's going to cut the event rate in half, but some major guidelines say if you're going to stop and aspirin would be safe in that patient, you can continue with an aspirin. There's some small degree of efficacy even in VTE. So the bottom line of this controversy, and I'm a Coke fanatic. I like it better than Pepsi. After initial treatment for, let's say, 6 months, consider indefinite prophylactic dose of apixaban or rivaroxaban for your patients with the first unprovoked VTE. You get a lot of the benefit and you'll minimize some of those long-term harms. All right, quick little time check. Oh, my time is there. Oh, thank you. Okay. Yeah, okay, good. So next, we'll move on. So submassive PE, also known as intermediate risk PE. When should we offer thrombolysis? So PE can be fatal. If the patient presents to your ER in cardiopulmonary arrest, they usually pass away, 70% death. If they come in shock requiring inotropic support and they're heading to your intensive care unit, 30% risk of death. And if you're like me and by now they're a little bit more stable, they're hemodynamically stable, about a 2% risk of death, which is not small. And within the 2%, you can further, stratify them based on clinical prediction rules, cardiac biomarkers, and assessment of their RV function. So high risk, also known as massive PE, they're hypotensive despite IV fluids, right? Those patients need thrombolysis or thrombectomy. That's clear. What about submassive, also known as intermediate risk PE? There's some cardiopulmonary impairments. They're tachycardic, they're tachypneic, they're hypoxic, they're JVD, they're diaphoretic. There's signs of RV strain. On the CT angio, the RV is as big as the LV or maybe bigger. That's your first hint. On the echo, you see signs of RV strain. The biomarkers, troponin and BNP, may be elevated. If only one of those is positive, the biomarkers or the RV, it's intermediate low risk. If you're both, the biomarkers elevated and an abnormal RV on imaging, intermediate high risk. And that's a question of how these patients should best be managed. When should they get thrombolysis? The biggest study of this was the PYTHO trial, about 1,000 patients who were randomized with submassive PE. And they were randomized to thrombolysis or standard of care anticoagulation, looking at death or hemodynamic decompensation within 7 days. And the result was very positive for thrombolysis. And you can see the top row, primary outcome reduced 5.6% to 2.6%. But most of that was in not needing a secondary thrombolysis. So death was not different. So no change in death. So it was mostly based on the secondary benefit. But there was increased risk of extracranial bleeding and hemorrhagic stroke. So that's the big trade-off when you offer thrombolysis to our patients with intermediate risk PE. Catheter-directed thrombolysis is an opportunity to deliver thrombolysis directly to the clot. Often it's ultrasound-assisted. There's very little, a surprisingly small amount of RCT data looking at catheter-directed thrombolysis, which some centers really do like. There's one study that's out there and not looking at death, but looking at a proxy, a marker of pulmonary function, looking at RV strain. And it was successful, reduced RV strain. Again, not powered to look at mortality. Then you have the Muppet trial. I don't know if you guys are familiar, but it's the Muppets are out there. I think of the Muppet trial like the Muppets. It's sweeter, it's calmer, it's gentler, it's a smaller dose. It's basically lower dose thrombolysis for patients with pretty large PEs. And this was pretty successful also. Everyone gets standard of care. Here it was low molecular heparin or IV heparin, and one dose gets the low dose or the thrombolysis. Again, not powered to look at some of the outcomes I would care about, like death or deterioration. Looked at pulmonary hypertension at 28 months. And it was highly successful, reducing the rate from 57% rate of pulmonary hypertension in the control group down to 16% in the thrombolysis group. So some data out there showing that possibly low-dose thrombolysis may be helpful, has not caught on. Some data on catheter-directed thrombolysis, but not that much. This is a meta-analysis looking at thrombolysis, and you can see the red arrow there and the diamond is off to the left, favoring thrombolytics for mortality in pulmonary embolism. And if you break that down, all-cause mortality with thrombolysis was reduced from about 4%, is the top row, to about 2%. So mortality is reduced when we give thrombolysis. But major bleeding goes up from 3% to 9%. Intracranial hemorrhage goes up to about 1.5%. That's quite substantial. And if you look at the subgroup of patients at the bottom of the table, all-cause mortality is also reduced. These are our intermediate risk submassive PEs. Death is reduced from 3% to 1.4%. But you get a corresponding increased risk of intracranial bleeding and major bleeding. Here, major bleeding increased. So it's a balance. Small decrease in mortality, similar increased risk of major bleeding, even intracranial bleeding. So what do the CHEST guidelines say? Well, the CHEST guidelines say standard of care, if you're in that 2% range, if you're not coming in shock, not on inotropes, standard of care is going to be conservative management, anticoagulation, and close observation. They're not hypertensive. We recommend against systemic thrombolytic therapy. It's a bit of an oversimplification because we've probably seen patients on the wards, giant saddle PEs, large residual proximal DVT, no pulmonary reserve. And if you have a PE response team or you have some experts and they're going to say, we really should go after this and treat with thrombectomy, thrombolysis, they're not wrong. You're going to have to apply this individually to your patients. But routinely, for your intermediate risk PEs, standard of care would be conservative and close management. So in select patients who they deteriorate after starting anticoagulating therapy, but not yet hypotensive, then you're going to think about thrombolysis. And the first sign is going to be tachycardia because the pulmonary hypertension increases, RV return decreases, the stroke volume goes down. The only way to maintain any cardiac output and blood pressure is to get tachycardic. So keep red alert for signs of tachycardia and other signs of strain for your patients in those first 24 to 48 hours. This is Ali and Frazier, and another controversy with the winner here being to not give routine thrombolysis for all of our patients with intermediate risk PE. Now, last topic. When is the rock and the hard place? When can I restart anticoagulation for my patients with major bleeding? So I'll start with GI bleeding. And what goes through your mind when you have someone who comes into you on GI bleeding on anticoagulation? First, what's the cause and has it been addressed? It could be a peptic ulcer that has been identified in EGD. It's been sclerosed, it's been injected, something's been banded, the bleeding has stopped, and you're feeling pretty comfortable. Or it could be someone who's had upper and lower endoscopy, and now they've done a capsule and we can't find it. We still don't know where it is. Looks like the bleeding stopped, not exactly sure where it came from. Much less comfortable restarting anticoagulation there. And the third is you know what it was and you can't address it. Big fungating ulcerated colon cancer in a 98-year-old. We know what it was. It's not going away. Not going to be too comfortable restarting. Risk of rebleeding high. What's the risk of thromboembolism? The best predictor of an event is that it happened recently. Have they had a thromboembolism before? How many have they had? And what's the CHA2DS2-VASc score to predict what it may happen in the future? And do not forget goals of care. And this is fairly common on the wards. Someone's been on anticoagulation for a long time. Now they have for AFib. Now they have GI bleeding. Not exactly sure where it was. Not exactly sure if you can intervene. They're 93 years old. Maybe they don't want to spend the rest of their days back and forth from the hospital with bleeding episodes. You have to talk to the patient and the family about whether they want to stop, even for AFib. The best study in GI bleeding is this study by Qureshi's group. This is a retrospective cohort study, AFib with GI bleeding on warfarin, a vitamin K antagonist, 1,300 patients, and about 49% of patients had anticoagulation restarted. That's a coincidence, not a randomized trial. But they looked at event rates based on whether anticoagulation was restarted or not, and the timing. And it's maybe a little bit hard to see from the seats, but I'll talk you through it a little bit. If you start within the first 7 days, 1 week, or 3 weeks, the risk of thromboembolism goes down quite a bit, and the risk of mortality goes down. If you're able to start in the first 3 weeks, that's these 3 columns. Now, if you restart early in the first 1 week, your risk of bleeding triples. So if you restart in 1 week, your risk of bleeding triples. If you start in the first 3 weeks, your risk of thromboembolism and death go down. So your sweet spot becomes the 1 to 3 week period. And I rely on that greatly, especially if it's been addressed and the bleeding has stopped. I'll often lean towards 1 week if the endoscopy was done and GI is feeling confident, I'll push it out to 2 or 3 weeks if you're less sure. Intracranial bleeding, much harder to know exactly how to manage, much more individualized. It's always individualized. This is one of the studies. I like it because the acronym is called BRAIN. I love that title of a study. Consecutive patient with warfarin-related intracranial hemorrhage in Canada, 280 patients. Warfarin was restarted in the hospital for 32% of patients. Who got restarted? A lower severity intracranial hemorrhage, makes sense, and patients with a mechanical heart valve, because there's an imperative to restart. The best predictor of death was restarting warfarin in the hospital. And it's not that restarting warfarin is magical. It's that who do we restart warfarin on? It's patients with lower degrees of intracranial hemorrhage, patients who are healthier, patients with lower risk of bleeding. But if you're able to restart warfarin, it is at least associated with decreased mortality. This is a retrospective review of patients with warfarin, on warfarin after intracranial hemorrhage who had warfarin restarted to see if you can find a sweet spot there of when you should restart. And, here again, it may be hard to see exactly, but the bleeding risk per day is fairly appreciable in the first 1 month and the second month, but around day 60, the incidence per day goes down quite a bit. And we'll wrap up. So this basically tells you that the sweet spot here of decreasing intracranial hemorrhage and before the increased risk of ischemic stroke gets too high is somewhere around 6 to 8 weeks. And basically, here's another study showing that, is it non-inferior? Is it safe to restart anticoagulation for these patients? Non-inferior was not shown. Anticoagulation may be inferior for our patients. And the guidelines will tell you, for patients with intracranial hemorrhage and patients with high risk of thrombosis, like mechanical heart valves, try to restart early. So if your patient has a mechanical heart valve, you're going to try to restart within a week or 2 if you can. But AFib is very different. AFib is phrased as if you restart, meaning you don't have to restart because the risk is that high of rebleeding and recurrent intracranial hemorrhage. Then you might want to delay for as much as 6 to 8 weeks or 7 to 8 weeks here. All right, the bottom line here of this one, you want the porridge to be just right. 1 to 3 weeks after GI bleed, about 6 to 8 weeks after intracranial hemorrhage if you restart at all. And that's it. We made it through all of them. Their take-home points here. In CKD5 and dialysis patients, DOACs appear to be as effective and at least as safe as warfarin. After a first unprovoked VTE, consider indefinite prophylactic dose apixaban or rivaroxaban. For your intermediate risk PE patients, reserve thrombolysis for patients who worsen with conservative management. And anticoagulation after bleeding is highly individualized. Sweet spots often 1 to 3 weeks after a GI bleed and 6 to 8 weeks after intracranial hemorrhage if you restart at all. Thank you very much.
Thank you so much, Professor Dunn, for that wonderful presentation. Due to interest of time, we will not have questions and we'll invite you to give away the certificate of appreciation done by Dr. Kumudini Jayasinghe.